All, all right, everybody. So we're going to get started. Julie, thank you for being here this morning. Dr. Lucero will be running this part of it today, and I will be in the background because, like many of you, I am multitasking. So take it away, Dr. Lucero.
Thank you, Jose. So as you all know, first of all, thank you for being here. Good morning, everyone. I am Julie Lucero. I am an associate professor in the School of Public Health at the University of Nevada, Reno, and also the director of the Latino Research Center, which is in the College of Liberal Arts at UNR. This is our second installment of the CBPR Training Institute, second of 3. And today we have some really fantastic examples of community-based participatory research in action. Today we are joined by Dr. Johansson, who is the assistant professor at the UNLV School of Public Health, Dr. Sharma, who is a professor in the UNLV School of Public Health, Dr. Jennifer Carson, who is the director of the Dementia Engagement, Education, and Research Program, which is at the School of Public Health at UNR. And also, we are very excited to have Dr. Habush Deloy, who is the director of the Nevada Institute for Children's Research and Policy. So each one of these, except for Dr. Habush Deloy, has created a presentation, a pre-recorded presentation for us. And then Dr. Habush Deloy is joining us in person. So we're going to move through the videos one after the other, in which case I invite you to note points of discussion or questions in the chat. We will have the fantastic Miss Sarah noting all of your questions. And then at the end of the entire session, so after Dr. Habush Deloy goes, we will open it up for discussion. A couple of things to note in these presentations is we've asked or we've charged these speakers to, one, tell us about their partnership that uses community engaged practices, and to tell us any sort of nuance about what it takes to have a successful partnership. And also you will notice that not everybody uses the term community-based participatory research. Instead, the practices may be very similar, but they might use a different framing for it. And the purpose or the reason for that really is dependent on their philosophy, who they were trained by, and then what discipline it is that they come from. So just keep note of those unique points of the presentation. But at this point, let's go ahead and move forward with Dr. Christopher Johansson's presentation.
It's Chris Johansson. I'm assistant professor of social and behavioral health at the University of Nevada, Las Vegas School of Public Health. And I'm happy to share my experiences using community-based participatory research and discuss my various experiences, as well as what I kind of hope to continue to use CBPR principles and methodologies in my research here at UNLV. Now I want to touch on my own experiences with community-based participatory research, talk a little more in depth about 2 projects that I was a part of in my graduate years at San Diego State, as well as my postdoctoral fellowship year a few years ago, addressing obesity in preschool settings. And then finally, I'll conclude with some future directions I would like to take using CBPR here in Southern Nevada, working as an assistant professor here at School of Public Health. So the first study I'll briefly talk about is called Familias Sanas y Activas 2, or Healthy and Active Families 2. And it was led by Dr. Guadalupe Suchiayala at San Diego State, and she was also part of the San Diego Prevention Research Center. And the reason why it's called FSA 2, or Familias Sanas y Activas 2, is because there was early success in Familias Sanas y Activas 1. So which began around 2005, and then the study went from 2005 to 2011. The purpose was to increase, using community-based participatory principles and a community health worker model or promotora model to offer free physical activity and lifestyle classes throughout various communities in southern San Diego County. And the goal was to increase physical activity, as well as see changes or significant changes in the intervention group of lower BMI. And there's also other secondary aims that I'll discuss as well. But just to mention, so the success from that first study kind of dovetailed into that second this study that I was able to work on as a graduate student. And so it was a 5-year study that utilized, it was a randomized control trial. So there were 3 communities. Here you can see Chula Vista, National City, and San Isidro were the 3 communities. National City, San Isidro, and Imperial Beach were the 3 communities that were used in this study, and recruited about 400 Latinos from these different communities. And again, it was a randomized control trial. So the control city was National City, and then the other 2 communities actually received the intervention. And again, the intervention, to briefly tell you, was that promotoras were trained nutrition and health expert coaches to deliver free Zumba classes, free physical activity classes, so Zumba, strength training, and other types of classes that promotoras were interested in teaching. And they taught them all throughout various different community centers, apartment complexes, and even community, like city, community senior citizen centers, a lot of different community centers where people typically gather. So it's free and open to the public. But the 400 Latino men and women who were a part of the study were kind of had sign-in sheets and reported every time they attended these physical activity classes, as well as there was about 10 lifestyle classes throughout the intervention. So the pre to post lasted about 1 year. And the lifestyle intervention classes lasted about 10 weeks, and it was offered various different classes and workshops about like cooking, physical activity, diabetes, chronic conditions, emergency preparedness. So it was a continuum of different types of lifestyle classes. And what the intervention found was that from those who were in the intervention group compared to those in the control after the intervention was over, there were significant changes in blood pressure, waist circumference size, improved symptoms of depression, and increased flexibility. Again, for those who were in the intervention arm compared to those who were in the control group. So my experience with that was coming in as a grad student. I had there was a lot of listening, attending lots of meetings, community advisory board meetings, community engagement meetings, helping recruit participants for the study, entering data manually, and also cleaning, analyzing that data. So I had a wealth of experience just from this one study on its own, but I was able to see all the different components and layers there are to CBPR. So this kind of helped me want to continue to use CBPR in my own research. And so I think this is a really good prime example of just by being familiar, just being aware of it, and having the success that this study had kind of also showed me that this CBPR has very strong research and as well as community reach, so that we could both be able to conduct our research as researchers, but also involve the community to make all these substantive changes and these lifestyle changes, and try to maintain and sustain them over time. And so for this study, it started it started in 2005 and lasted 2015. That's pretty sustainable, especially in research terms. Usually it's always dependent on funding, but 10 years is not something that's something to be very proud of. And then again, so there's the researcher, the PI, Dr. Ayala. She has extensive roots in the community. She's from the area. She knows the community very well, and she's well established as she built up that rapport and trust, and that's something I would like to try to attempt to do, and I want to do here in Las Vegas, in Nevada as well. So definitely something that's very important to me, and figuring out what the community needs, and then coming together, meeting, seeing where we could help each other out as far as with respect to perhaps developing research questions, the expertise from the community, and the community what they know, the community knows what's needed. So definitely a very good relationship forming this rapport and building it here can definitely help for future potential research ideas to collaborate on. So here's an example of the community partners that FSA, Familias Sanas y Activas 2, used. This is just a pretty extensive list from the city of San Diego, the departments of rec, various apartment complexes, Casa Familiar, San Isidro Health Center, even some elementary schools were a part of very important aspects where contacted the principal and asked if they could use their gymnasium to hold these classes. So as an example, the school district, the university, as well as the research center. So all played a key component in order to make this intervention a success. Here's just some intervention materials that were developed for the study, as well as a community Zumba free to the public, where people are able to conduct a Zumba class, get the physical activity, as well as kind of also build up that social support, where having that community, talking with them, getting to know them, etc. Here are just a few more images of a indoor Zumba class, as well as outdoor, and then even just the core of the promotoras, the community health workers that were delivering the intervention, as well as some of the Dr. Ayala and some of the other key members of the team in part of the study. The next study I would like to talk about is ABC Healthy Me, or ABC Healthy Me Soy Saludable. And this study is currently being led by Dr. Roshan Bastani and Paul Chung at UCLA's Fielding School of Public Health, as well as the UCLA Kaiser Permanente Center for Health Equity and its community partner, their Child Care Resource Center. Recruitment started in 2019. It's currently ongoing and expected to be completed in 2023. The goal of this study is to have a multi-level intervention to impact preschoolers' body mass index, or BMI. So, for example, some of the levels that are targeted here in this intervention include training or coaching the teachers to this new curriculum to increase nutrition, physical activity curriculum in the preschool site, and also could also indirectly affect the teachers because they're being coached on this, as well as site directors are implementing at the policy level, working with them to see if there are policies that are currently in place that could be enhanced or improved to be able to have kind of a healthy by default framework in which maybe perhaps, for example, for birthday celebrations, offer a healthy snack or an alternative as opposed to maybe a giant cake, maybe even just small changes such as instead of a big slice of cake, maybe just a mini cupcakes. So a lot of different ideas in order to change some of these policies within these sites to help have improved nutrition and physical activity outcomes. And the preschool also try to affect change within parents, since if the children are attending preschool, it's probably, we could assume that children spend at least half their day at this preschool or more if parents working typical 8 to 5, 9 to 5 jobs. So almost the whole day. So they're there Monday through Friday, 5 days a week, like students like in a school district. But the policies are not all uniform. So trying to show that if we're able to even change some parent behaviors, that we could indirectly affect parents with their perhaps dietary nutrition choices as well as their physical activity, and try to get them engaged with their child to do different activities, such as having a 30-day physical activity challenge or a 30-day fruit and vegetable challenge, or healthy snacks, healthy lunch alternatives on the weekends, etc., just to get them engaged, and they may indirectly be affected by this intervention as well. And again, the primary aim was to increase or decrease child BMI, increase, and some secondary aims include increased their physical activity, increase their nutrition with respect to more consumption of fruits and vegetables at the school level, at the site level. And so far, and the methods are using community-based participatory methods. So UCLA is kind of has been collaborating with CCRC for over 15 plus years as well on various interventions and studies throughout the careers of Drs. Bastani and CCRC. And so the methods, the intervention aims to recruit about 60 preschools, so that's family child care centers. Those are like those in-home daycares, as well as early education centers in the San Fernando and Antelope Valley communities of Los Angeles. And this is typically, there's lower income, lower education level, higher immigrant population. So it's a very a need in this community because obesity and the prevalence of obesity in preschoolers is a lot higher in these communities compared to other parts of Los Angeles County. And so that, as I said, so recruitment is still ongoing, but kind of some preliminary analysis that we've kind of discussed, that kind of has been reported from the first year and a half of this study, has kind of suggesting that there's starting to be a trend and a change in BMI from those in intervention compared to those in the control arm. So hopefully, if those results still hold or improve over the next 2 to 3 years, that this intervention will also show that there's a potential successful curriculum that could decrease preschool age children's BMI. Some images of intervention sites doing various activities, such as sampling different fruits and vegetables, doing different types of dances and physical activity movements, indoor and outdoor. Here's outdoor, trying different fruits and vegetables, playing various games, so giving a lot of different options and variety for teachers to take, to choose the ones that they think that children will really like or really want to continue to do even after the intervention. So again, for that maintenance, to maintain and sustain this curriculum. Here's some images of children planting various fruits and vegetables. So having curriculum of different fruits and vegetables, but also matching them to the shapes, dressing up, having as a chef and the type of their favorite fruits or vegetables. And I really like this one because, again, this is someone's birthday party. Instead of cake or cupcakes, an alternative snack was they made kebabs of cut up fruits such as strawberries and bananas. So that's a very creative idea, and kids still getting their celebrate with their peers, but also having a healthy alternative dessert. So that concludes my 2 experiences with CBPR, and now I'm looking towards the future to develop my research here in Southern Nevada using CBPR principles. And so I'm currently still thinking of some ideas and some trying to identify potential partners who are interested in addressing Latino health disparities in Nevada. So if you or anyone you know might be interested in collaborating, I'm definitely open to that. Setting up meetings to discuss any potential collaborations or mutual interest. I'd like to thank you for taking the time to listen to my presentation today about my experiences using CBPR. And here's my contact information if you have any follow-up questions with respect to the presentation, or again, if you're interested in potentially collaborating or learning more about CBPR in general. My contact information is right here. It's christopher.johansson@unlv.edu. Thank you for your time.
Wonderful. Thank you, Dr. Johansson. So while he provided a pre-recorded video for this session. Dr. Johansson will be joining us towards the end. So if you do have any questions for him specific to his projects, or if you want to ask questions about potential collaborations or any points of discussion, please add them to the chat and we will be monitoring that so that we get back to them at that point of discussion. So at this point, we're going to move forward to Dr. Sharma's presentation.
And just quickly before we start, I want to remind everybody that's on the call with us today on the Zoom, please put your name and your information in the chat if you haven't done so yet. Thank you, everybody.
Welcome to this session on examples of community-based participatory research and evaluation that I have conducted. My name is Dr. Manoj Sharma, Professor and Program Coordinator of the Social and Behavioral Health Program at the UNLV School of Public Health. My email is manoj.sharma@unlv.edu. If you have any questions, you can email me. So the examples of CBPR that I have done are participatory evaluations of community-based rehabilitation and other country projects in Vietnam, Mongolia, India, participatory evaluations of minority health projects in Ohio with Ohio Commission on Minority Health, participatory evaluation dovetailed with process evaluation of public health disparity work here in Nevada, which is ongoing. And I have used the Freudian model in needs assessment and evaluation of coalitions. So I will share these through case studies. So the first case study that I have is a participatory evaluation that I did in Vietnam. And the context is that Vietnam is a poor nation, and the statistics that I'm giving is old at the time when I conducted this participatory evaluation. It's a densely populated nation. 35% of the population was less than 14 years. Life expectancy was 67.74 years. Infant mortality ratio was 36 deaths per 1,000 live births. It had a very high literacy rates because it is a communist country. So 92% literacy rates, and health budget was also 3.1%. And the project that I focused my participatory evaluation was community-based rehabilitation project, or in Vietnamese known as Phúc Hoi Chuk Nang Dua Wa Kong Dong. And the method that I utilized primarily from participatory evaluation was the construct of dialoguing from the CBPR or Freire's model. And I collected the data at the village level, the commune level, the district level, the provincial level, and the central level. So it entailed several dialogues with village people, with commune people. Commune is like a county, and then district level, and then at the province level, provinces like the state, and at the central level or at the national level. So I first reviewed a lot of documents, and then I conducted these dialogues. And then I organized these along a thematic analysis. When I collected all the data, rich data from the participants, I did the thematic analysis along the framework of strengths, weaknesses, opportunities, and threats, also known as the SWOT framework. And I compared them against the 5 principles of the WHO model regarding community-based participatory, community-based rehabilitation projects. So the first principle was utilization of available resources. The WHO says that we should utilize the resources that are available at the local level. And that was found as a strength. For example, they were using bamboos available to make crutches and things like that. And then transfer of knowledge was also found as a strength because it was a very good structure from the commune, from the village, commune, district, province, central level, so the transfer of knowledge was taking place from the central level all the way to the village level. But the area of community involvement needed improvement. As I mentioned, that it was a hierarchical structure where the information was flowing from top down, but not from down up. So that is one of the hallmarks of CBPR, that it should flow from the community, and that was not what was happening. And then utilization of referral services was found as a strength. Once again, village was able to refer to the commune, and commune to the district, and then the province, and so on. So that referral structure was very good. And then coordinated multi-sectoral approach needed improvement, because there was not much. It was only health agencies that were involved, and other agencies were not involved. So that needed improvement. So that is what the recommendations I provided based on this participatory dialoguing that I had at the various levels. And then the second case study that I'm going to present is about the participatory evaluation of local offices of minority health in Ohio during COVID-19. And then, as you know, that minorities continue to lag in health indicators in the US, in Ohio also that is the case. So in Ohio, what they have done is the Ohio Commission on Minority Health, OCMH, has funded 6 local offices of minority health, LOMHs in Akron, Summit County, Cleveland, Cuyahoga County, Columbus, Franklin County, Dayton, Montgomery County, Toledo, Lucas County, Youngstown, Mahoning County. And these have been functioning for several years now. And they foster community-based approaches to addressing health equity among minority populations. So we looked at, I have been associated with this project for the last 16 years, and we looked at specifically what is going on during the COVID-19 pandemic last year. So the core competencies that LOMHs strive are monitoring and reporting the health status of minority populations, informing, educating, and empowering people, mobilizing community partnerships and action, developing policies and plans, and making efforts for sustainability. So there are 5-pronged approaches that these LOMHs follow. So the approaches that we followed was participatory evaluation, was based on the tenets of community-based participatory research. Each participatory evaluation was conducted through a partnership between REAP, which is the Research and Evaluation Enhancement Program, panelists and project functionaries of LOMHs. A thematic analysis of the lessons learned in the context of social connectedness efforts was summarized, because that was the theme we focused during the COVID-19 pandemic. So selected tenets of CBPR that were used in participatory evaluation was the formation of a long-standing partnership between the REAP panelist and the project personnel. As you know, CBPR has a long lead time. So this partnership has been going on, as I mentioned, for the last 16 years. And in quarterly or more frequent meetings using a mutually agreed template. So we've developed a template along which we have monthly or quarterly meetings, and then joint reflection and problem solving on quarterly challenges. In that template, we reflect on what are the obstacles and try to jointly solve the problems. And the project ownership of successes is held jointly between the project and the REAP. And empowerment of LOMHs is the goal. And utilization of cultural humility goes all along in this partnership, and the focus is on capacity building. So we build the evaluation capability of the LOMHs in the process. So the lessons learned during COVID-19 was that LOMHs that discovered that alternative venues, for example, video conferencing, Zoom, WebEx, could be effectively used to manage meetings, inform and educate the community, and build social connectedness. They also realized that partnerships were essential for successful efforts. flexibility and collaboration with internal and external partners were needed to address the pandemic. And then sustainability can be achieved through the work of stakeholders and general community support, as well as initiatives to secure funds. And then efforts directed to public policy lead to positive critical decisions and resolutions. And then media and public relations promote visibility and raise awareness about the important work of the LOMHs. So the partnership of use of social media and the partnership with media organizations is also very important in this kind of work. And then LOMHs met the challenge of translating COVID-19 related educational materials in different languages, which were urgently needed to inform and remain connected with new immigrants. For example, Nepalese community, Bhutanese community, Turkish community, Somalis, Rwandans, Spanish speaking, etc. Now these communities are prevalent, are based in Ohio in large numbers. So that is why the need was there. And then LOMHs found that social media, for example, Facebook, Instagram, etc., and websites could become primary modes of communication to improve social connectedness. And the recommendations for practice were that LOMHs are significant contributors toward improving the health and social connectedness of minority communities in the various regions of Ohio. And these efforts done by LOMHs in Ohio can be replicated nationwide to improve minority health. And the third case study and the final case study that I'm going to present is that CBPR dovetailed with process evaluation. So as some of you may know that Nevada Department of Health and Human Services has received a $32 million grant under the National Initiative to address COVID-19 health disparities among populations at high risk and underserved, including racial and ethnic populations and rural communities. So we have been involved in the process evaluation, and that is what we have dovetailed with community-based participatory research. The project is started on July 1st, 2021 and is finishing in 2 years on May 31st, 2023. So we have a number of partners in this grant, like the Department of Health and Human Services Office of Minority Health and Equity is there. The Grants Management Unit is there. The Behavioral Health Wellness and Prevention Unit is there. Nevada Cancer Coalition is there. Healthy Communities Coalition is there. Department of Child and Family Services is there. Nevada Office of Rural Health is there. Southern Nevada Health District is there. Washoe County Health District is there. Carson City Health and Human Services is there. Blueprint Collaborative is there. KPS3 is there. Nevada Broadcasters Association is there. So there are a number of community partners, and that is where the community-based participatory evaluation comes into interplay. So what the process evaluation that we are following is with the RQFSM, participatory RQFSM model: reach, quality, control, fidelity, satisfaction of the participants, and management of the project. So these are the 5 dimensions of process evaluation, which we have incorporated in a participatory manner. It involves active engagement of the partner organizations, assessment of the engagements, and deliverables in the form of quarterly reports. So the first component that we have chosen is the reach. Reach is basically how many participants reached, whether intended minorities were reached, were any additional participants not intended reached, did the community members know the programs were available. So those are the targets of our reach. And the potential methods that we are using in the participatory process are number of counts from the reports submitted by the units, descriptive demographics from the reports submitted by the units, descriptive demographics from the reports submitted by the units for participants not reached, and then focus group discussions with the community members. And then for quality control, the main targets are for resources in terms of staff, facilities, money, adequate to support high quality delivery, and that did the intervention staff work effectively. And then the methods that we are using are interviews with program staff, focus group discussions with community members, reports submitted by units, observations, interviews with program staff, reports submitted by units. So those are the various kinds of activities that we are indulging in. And then for fidelity, which is whether the program is being delivered as planned or not, we are looking at the activities, whether they were delivered as planned. Did the participants receive the intended amount, type, and quality of services? Were there any modifications from planned activities? Were the essential components delivered well? So for delivery as planned, we have checklists. We are reviewing the program reports. For participants receiving the intended amount, type, and quality of services, we have focus group discussions with community members, interviews with community members, review of program reports submitted by units. For any modifications and components being delivered well, we have focus group discussions with community, interviews with community members, review of program reports submitted by units. And then satisfaction of the participants. For satisfaction, the targets are, were the participants satisfied? Did the participants utilize all services? Was adherence adequate for project delivery? So for the participant satisfaction, we have rating surveys that we will be employing through Qualtrics and paper and pencil method. Did the participants utilize all services? We have focus group discussions with community. We have interviews with community members. Was adherence adequate for project delivery? We have interviews with program staff. We have review of program reports submitted by the units. And then for the management of the project, did the project comply with the professional standards, funding agency requirements, legal standards, and agency administration? We have the review of program reports. We have interviews with program staff. We have observations. Were the resources used efficiently? We have review of the program reports submitted by units, interviews with program staff, observations. So all these methods are being done in a participatory manner. So that is all I have for the 3 case studies that I shared with you in terms of the community-based participatory research and evaluation that I have been doing over the years. If there are any questions, please email them to me at manoj.sharma@unlv.edu. Thank you very much.
Excellent. Thank you, Dr. Sharma. So we have one more presentation to view, and this is, before I start that, I want to thank any newcomers for joining and just remind you that this is being recorded for educational purposes. Also to add your name and organization, contact information into the chat box. And at the end of our presenters, we will have, or when our presenters have concluded, we'll have a session for a live question and answer session. So with that, I would like to introduce Dr. Jennifer Carson, who is the Director of the Dementia Engagement, Education, and Research Program at the UNR School of Public Health.
Hi, everyone. My name is Jennifer Carson, and I'm Director of the Dementia Engagement, Education, and Research Program in the School of Public Health at UNR. Thank you for this opportunity to come and share a little bit about my work using critical participatory action research to transform the culture of dementia. I have a very ambitious agenda for us. In 15 minutes, I hope that we can explore what critical participatory action research is as a methodology and tell you a bit about its theoretical foundations. In fact, that's the order I'll do it. First, describe the methodology of participatory action research, and then add the critical component. And then I will provide examples of CPAR in action within the context of dementia. So first, a definition, and I'm going to read it word for word and commit PowerPoint sins here. But it's important. I want to share this definition with you. It's interesting. This definition for participatory action research was developed through participatory action research. So a bunch of researchers got together and they used PAR to actually define what it is. And it's a really great definition, but it's a little bit long. Here it is. If yours is a situation in which people reflect and improve their own work and their own situations by tightly interlinking their reflection and action, and also making their experience public, not only to other participants, but to other persons interested in and concerned about the work in the situation. And if yours is a situation in which there is increasingly data gathering by participants themselves in relation to their own questions and participation in decision making, and there's power sharing and the relative suspension of hierarchical ways of working in a conscious move toward social democracy, and collaboration among members of the group as a critical community. And if yours is a situation in which there is increasingly self-reflection, self-evaluation, and self-management by autonomous and responsible persons and groups, and there's progressive and public learning by doing and making mistakes, and a reflective spiral of planning, acting, observing, reflective planning, etc., and reflection that supports the idea of the self-reflective practitioner. If all that's going on, then yours is a situation in which participatory action research is occurring. Now, sometimes in the literature, you will see participatory action research represented by this spiral of reflect, plan, act, observe, reflect, etc., these iterative cycles. And there are iterative cycles, and part of this is true, but this particular representation of PAR is not reflective of my experience with critical PAR. Rarely does a project ever unfold in such a linear and orderly fashion. This is what my experience has been, folks, especially if you're committed to authentic engagement and collaboration, and you know, these are human beings and we're working together and it's always messy. And yeah, we're going to make mistakes. And then we're going to learn from those mistakes and we're going to do better. Then things are messy. Participatory action research is a messy, messy endeavor, but really worth it. My gosh, PAR can really produce impactful and lasting changes. So now let me add the critical part to critical participatory action research. The critical part is that critical PAR is really built on the foundation of Jürgen Habermas. He's a German social theorist, and he wrote the theory of communicative action. And I think he describes his theory over 3 volumes of text, rather lengthy, but Kempis and McTaggart kind of provide a great succinct summary for us here. They say that communicative action is the type of action that people in groups, like participatory action research groups, take when they consciously and deliberately aim to reach intersubjective agreement as a basis for mutual understanding, so as to reach an unforced consensus about what to do in the particular practical situations in which they find themselves, thus opening a communicative space between people, which not only achieves practical action, but it also builds solidarity, and it underwrites their understandings and their decisions with legitimacy. So that just a little bit about the theory of communicative action, which again gives this particular research methodology its critical element. So CPAR. All right, I use another process within my CPAR projects because I work with people living with dementia. I use a process to reflect on my CPAR process called authentic partnerships. Authentic partnerships is a framework that helps us to consider certain principles and enablers to supporting the genuine inclusion of all stakeholders, including people living with dementia and care partners, not caregivers, directly in decision making. And so this was actually a framework that I developed in partnership with my colleagues at the University of Waterloo, in partnership with people living with dementia. We use participatory action research to actually develop this framework to reflect on the quality of our engagement with people living with dementia. And it's been a really helpful part of my research to have that as a framework to reflect on the quality of my work. So now let me give you 3 quick examples of PAR in action, critical PAR. For each one of these, I want to tell you a little bit about how that partnership was started, how the topic or the project was decided upon, the group processes that we used, and then key milestones. So this first PAR project, CPAR project, was actually intended to disrupt ageism and dementiaism, which is like ageism and ableism coming together in lethal force. And so the whole goal here was to develop a script for a nonfiction theater performance titled Disrupt Dementia. And what we meant by that was that we really wanted to disrupt the tragedy narrative of dementia and open up the possibility for living well with dementia. And so this partnership was started by this guy right here, Dr. Bill Thomas. He's a geriatrician, and he gathered a very interdisciplinary group of us together, musicians, academics, practitioners, and together we formed a group called Changing Aging. And so then Changing Aging, and led by Dr. Bill Thomas, really, I guess, suggested the topic of our performance, Disrupt Dementia. So then it was up to us to try to locate a group of people who really shared this interest in disrupting dementia. And we found that group in Seattle, Washington, an incredible group of self-advocates living with dementia called Momentia. So the Changing Aging team got together with Momentia in Seattle, and we used critical participatory action research and another form of action research called appreciative inquiry, which is a really cool strengths-based form of participatory action research. And we used the authentic partnerships framework for supporting the authentic partnership of people living with dementia. Those were the 3 group processes that we used together to develop our script called Disrupt Dementia. Super cool research process. It was so much fun. We had such a good time. And then we took that script on the road. We performed Disrupt Dementia in 52 cities across North America to thousands and thousands of people. Anyways, it was just an incredible research project, and I'm so grateful to my partners for being part of that script writing. Then another project, I want to tell you how I used CPAR to transform the culture of dementia right here in Nevada, specifically through the Dementia Friendly Nevada effort, which aims to develop and promote communities that are respectful, educated, supportive, and inclusive of persons living with dementia and their care partners. How did this partnership get started? Well, the Nevada Aging and Disability Services Division actually identified a funding opportunity from the Administration for Community Living to launch new dementia-friendly communities. And they convened a series of stakeholder meetings to try to identify interested partners, including family care partners and people living with dementia. And I just happened to be one of those partners. And so were dozens and dozens of other individuals who had a shared concern. And so I guess the topic or project was decided upon to a certain extent by the funding opportunity, but there was very, very strong support across the state of Nevada in really launching this new initiative and making it successful. So our processes included critical participatory action research to guide. Now we have 7, but when we first launched, it was to guide the work of 4 of our first community groups. So we were going to use CBPR as that unified research methodology and change strategy. And so we launched community groups across the state, all aimed at transforming the culture of dementia, enabling conversations and participation by all citizens, and especially people living with dementia. So in 2017, we launched the first 4 community groups, all using CBPR. 2018, we launched 2 more groups. And then in 2021, we launched 1 more group, and then we're ready to launch more. And you can see that these groups represent urban, rural, and tribal communities. So they are all very, very different, with very, very different partners at the table, but they are all using CBPR as that change strategy, and it's just producing incredible outcomes. Each of these community groups, I should say, have representation, really diverse representation from people living with dementia, family care partners, and representatives from different sectors of the community. And so wonderful to have such a diverse group of people together when we're talking about transforming the culture of dementia within a community. In addition to using CBPR, though, we are also using authentic partnerships, and we're also using a model for community-driven change that was put forth by Dementia Friendly America. And so it's using all 3 of these methodology or processes together to really mobilize community-driven change. And so it's just been awesome to see what has unfolded in this process. These groups have created their own peer support groups. They've created community awareness trainings, volunteer-hosted respite opportunities. They're really helping do early detection, early diagnosis, a variety of care partner education programs. They're developing tribal resources, and they're focusing on risk reduction and the promotion of brain health and meaningful and active engagement opportunities for people living with dementia. And of course, in all of our work, we help people get connected with other resources that are part of the Nevada Aging Services Network. And so these are just a few photos of that incredible work. It's just an honor to be a part of this effort. And if you want to read more about our work, I encourage you to go visit our website, dementiafriendlynevada.org. But then I just want to tell you about one more CBPR initiative that I'm so proud to be part of, and it's called the Quest Upstream. And in this case, we're using CBPR to really understand the enablers of dementia inclusion within residential care and support. I believe, as do my CBPR partners, that people have the right to live in a restraint-free world. And so in this case, the topic is dementia inclusion within residential care. What we're really doing is reflecting on and pushing back on the current memory care model. And we're saying, hey, you know what? This model resides on a base of human practice and human history. And since memory care has been humanly made, it can be humanly and humanely unmade. And so my partners and I, in this case, are using CBPR to unmake memory care and to use what we understand about care and support to promote inclusive care and support. So my partners on this initiative, the Quest Upstream, actually contacted me, and they said, hey, Jennifer, we know that we all have this shared value of dementia inclusion. We want to invite you to join us on a project where we really want to understand and document the enablers of inclusive dementia care and support. So this is Carroll Woods Retirement Community. They are a large campus, a continuing care retirement community in Chapel Hill, North Carolina, with over 500 residents, half of which are probably living with dementia, but there's not a single locked door. There's no locked and segregated memory care. And so they're really a shining example of dementia inclusion. And so they said what they wanted to do with CBPR in partnership with me was to understand and document the organizational and community requirements of inclusive living for people living with dementia. And while doing this kind of work, it was an opportunity for them to improve their practices. And so they said, while we're doing this research, let's use this research to actually improve our practices so that we could better support the well-being of all community members. And so they're improving their work as they go. I was thrilled to be their partner. I spent 1 week a month living at Carroll Woods in Chapel Hill, North Carolina for 18 months. This was our process. In addition to CPAR, we engaged this large communities actually divided into a series of neighborhoods. And so what we did was kind of an educational effort or process within the CPAR process. Then we convened a series of what we call neighborhood retreats, which were educational events where we invited residents, family care partners, and employee care partners to all come together to raise their awareness about well-being, to consider new ideas for better supporting well-being and inclusion, and then to identify some possible improvements. And then they would, after more reflection, democratically select a goal, one for each neighborhood, one for each retreat. And so that was a total of 5 goals per neighborhood over the course of this project. Again, there were 5 neighborhoods, so that's 25 goals that this organization developed, committed to, and took action on themselves. They used really great communication to help support their goal activity. Specifically, they used something called weekly neighborhood huddles, where they would gather all community members together on a particular neighborhood to actually develop an action plan. And then they took their learnings and reflections deeper, and the employee care partners, every shift, every day, had something called daily shift huddles. And they used this as an opportunity not just to talk about the quest upstream and their well-being plans, but it was also a great opportunity to improve communication and strengthen teamwork and really build their muscle for shared decision-making, all with the aim of better supporting well-being. So my partners and I identified a number of positive pathways to inclusion. That's the result of this work. And what's great, we make our work public. Of course, we blog about the quest upstream, so you can go onto the Changing Aging website, read about the quest upstream. And we've done lots of presentations. It's so important to make the work public. And then you can see here this last chapter in a new book called Happily Ever Older: Revolutionary Approaches to Long-Term Care. Carroll Woods and the Quest Upstream project were featured. And we're continuing our work, sharing about the quest upstream. My partners and I are writing a book together about it, which is pretty exciting as well. So critical participatory action research within the context of dementia, important for us to also reflect on how we're engaging our partners. I use the Authentic Partnerships framework for that. 3 different initiatives, all that aim to transform the culture of dementia using CPAR, but I think you can hear how each of these initiatives is incredibly unique. But also, I hope you can hear how powerful this methodology is. So thank you for the opportunity to share with you all. And if you have any more questions, or if you want to connect, you can find me at jennifercarson@unr.edu. Thanks a lot. Bye-bye.
Wonderful. Thank you, Dr. Carson. I always love hearing her present on her research and her partners because she's so excited about it, right? She definitely, the love for her work comes through in her presentations. And so now I'd love to, and I'm so excited to introduce Dr. Habush Deloy, talking about her work utilizing CBPR. So without further ado, I will hand it over.
Thank you. Can you hear me okay? Wonderful. And I also want to acknowledge that on this slide, this work was done actually under the Nevada Minority Health and Equity Coalition, and was done under the with Dr. Erica Marquez, who is on the line, so she might jump in if she wants to provide other clarification or during the Q&A. And we worked with an entire team of staff at both the Nevada Institute for Children's Research and Policy and the Nevada Minority Health and Equity Coalition Advisory Board. So we are all very, very involved in this process. So we're going to talk a little bit about today about some recent work that we did addressing the COVID-19 pandemic and the disparities that existed within its effect on minority populations. So our goals today are just to talk about how we use CPR to mobilize a community response for COVID-19, look at some of the main principles that we use to conduct community engaged outreach, and then how the methodology that we use to implement. So you can see here, on this picture from Time magazine, that we have been doing testing on people doing experiments for a very long time. And this is often how people can feel, right? That somebody's coming in and they're poking and they're prodding you. And so we kind of want to change that perspective. And I think part of the CBPR approach is that rather than having our participants in a little cage that we just poke at, is to bring them outside of the cage next to us. And so we are all looking at issues together and engaged and looking at the right methods to explore issues. And we are partners, not just seeing them as subjects. So looking at community engaged research on this continuum. So it's not on populations and communities, we are in populations and communities, and then moving really to work with populations and communities is our final goal. So here we can look at this spectrum that on how the least involved, I guess you can involve your participants in the community that you are interested in, and then what more engaged research looks like. So on the right end, you've got, community-led and controlled research that the community defines the issues and the research questions. They create and help create the data collection tools. They help recruit participants to collect the data, analyze the data, and disseminate the findings. So this would be, probably the optimal approach. It may not always be that, that approach can be attained through everything, but this is our goal. This is what we're striving to do. And I can say even in our research, I don't think we 100% got there because we had some of the questions beforehand. Some of it sometimes is led by outside of us. We got some requests from the state that we had to go to, so you don't always get to control every aspect of it, but that's kind of the goal, is to do that as much as possible. So, and the campaign that we're going to talk about today, again, is the One Community campaign. And this is where, again, we were trying to provide increased education and awareness into different minority communities or underrepresented, underserved communities. So that way they could have increased risk reduction to COVID-19. So we wanted to provide a central location where leaders and members can really get reliable information about COVID-19, given that there was a lot of mistrust and doubt about the information that was coming out. We wanted to make sure that we engage leaders and members as active participants. We wanted to engage the community in larger conversations. So we didn't want to just create a campaign that we thought addressed their needs. We wanted to make sure that we were creating it with them to find out what are your impacts, your perceptions, your concerns. So we were getting it from our community members in Nevada, not just looking at a nationwide sample, but making sure that we got our local perspective, so that way that could be addressed in the campaign. And then within this particular project, We looked at doing this through both digital sources and non-digital sources, because we know not everybody has access to technology. Even though a lot of people do, there are still some people who do not have access to the internet or a phone or things like that on a reliable method. And we did this in 7 target communities over a very short period of time, which was very ambitious, and it was a great experience. I don't know that we would do 7 again without more resources or more time, but it was definitely, it was a great way to engage multiple sectors in the community to make sure that we had information that related to them. So of course, given the name community-based participatory research, right, we definitely did not do this work alone. So you can see that we partnered with all of these different organizations who already had outreach into their community. They already had connections into the community. And so they were the ones who were helping us design and lead these efforts in order to make sure that we had culturally responsive material. And within this, we also made sure to write in the funding that we would be able to pay these organizations, because oftentimes we may reach out and seek that support, but we don't always do it with funding. And then it's an extra tax, especially on these, more vulnerable communities. These are the ones that, we need to build up and make sure that we've got increased funding available. So if we're getting funding for it, we want to make sure that we are also including our partner organizations with the funding. So we did sub grants to each of these entities in order to make sure that they were compensated for their time and make sure that they saw themselves as valued partners in the process, and that value included some monetary funds to go with that. So some of our strategies for engagement, actually, we'll go ahead and skip this slide and go on to the next one. I want to make sure people have plenty of time for questions. So this is kind of the model that we use. And I know that we've been talking about CBPR for a 4th presenter now. So hopefully that you're familiar with this process by now. So let's go ahead and go to the next slide. So these are the main efforts that we did in our process, and we're going to briefly touch on these. So one, we had focus groups. So again, with our community partners, we developed questions and implemented the focus groups. We'll go into that a little bit in a minute. And then we developed outreach materials from that, print material and social media, all in partnership. All of these were done in partnerships with all of those organizations that you saw listed. And Dr. Lucero is actually one of our organizations that helped us reach out into the Latinx community in Northern Nevada. So can personally speak to her experience. Hopefully we did a good job. So let's go into the next slide. So from our listening sessions, as you can see here, we did a lot of focus groups, right? So we did a total of 30 focus groups, and that spanned across a period of 2 months. So it was a lot of effort in a very short period of time. And so with our 10 to 11 funded different partners, we all worked together to develop the focus group questions to make sure that they were asked in an appropriate manner, that we had prompts that were culturally relevant. And then we also did a training session for those that didn't have experience in facilitating focus groups. We didn't want to just say, okay, give us your input. Now we're going to go into those communities and we're going to do the focus groups. We trained our partners on how to facilitate those focus groups in order to pull the information that we needed. And while we showed up to help support the focus groups, they really led the sessions in order to make sure that, again, that they were the groundwork, they were the trusted partner that was in the community. So when the community members showed up, we wanted to make sure that they were the ones who were involved in asking those questions. So this was the end result. You can see that these are all of the different populations that we worked with that were represented. And in total, we had 221 focus group participants, and we did very few sessions in person due to that this was the height of the pandemic, but we still had a couple in person because they wouldn't be able to participate with in another way due to some of those technology challenges. So we did it as safe as possible. And we were able to do the majority of them online and again, some in person. And then on the next slide, you can see, I'm not going to go over all these results, but you can see this is some of what we were able to pull together. So we looked at what were some of the commonalities across the groups, what were some of the similarities, so that way we could use some of these things in order to customize the different outreach materials to each group. So once we did this, we were able to go back and say, okay, this is kind of what we found. These are the materials, and then work with our groups to obtain feedback. So if you go to the next slide, we're going to take a look at a couple of the materials that we developed. So on the left, you can see that these were the flyers, The Pandemic Stops With Me. And we created one of these flyers for each of the 7 targeted communities. And we made sure to change the images, we changed the statistics, we changed the ways to cope at the bottom during the pandemic. We made sure that those coping strategies were specific to that population. And the graphics as well. So the little bars that you can see in the middle that are like the little suns, we made sure to change those in each of the populations as well. So that way, when somebody looked at the flyer, we were hoping that they would see themselves reflected and that they could better relate to the flyer, and hopefully that they would take the information in a little bit more and engage with the material. So those were flyers that we had handed out. We also had them translated into several different languages in order to accommodate the community's needs. And then on the right, you can see this was actually a postcard that was mailed to, I think it was over 30,000 households across, and it may have been more than that. Now I'm forgetting the numbers, but we wanted to make sure that if somebody didn't go to an outreach event or weren't at a place where these flyers were, that the most at-risk communities receive these right to their door so they could get that information. And again, since we couldn't mail different flyers to different households, we tried to make sure that our images were as diverse as possible, so somewhere in there somebody could see themselves reflected. And then on the next slide. So we had on the left, you can see all the different topics that we covered. And you can see these are some examples. We did My Ethnicity Is Not a Virus. We wanted to make sure to respond to the different discrimination instances that were happening around COVID. So we worked with the community members to develop these different messaging as well. And we did an explainer video that was an animated video on contact tracing. We thought that would be a little bit easier to understand. And I can tell you, this is one area where they need to do more work in diversity, that their animated characters are not diverse. So you have very slim pickings. And then the next slide. So, and we did a video series, and you can see at top, that was our billboard. So you can see more of our resources on the webpage, and we actually have toolkits, which I think are on the next slide. You can see we developed a toolkit for each of the populations that you can go and see all the materials that were created. But at the end of the day, we got very positive feedback and said, you know, when I look at this, I really do see that my community is reflected. I haven't had something that was customized to me before. So we were really happy that we were engaged, and you know, some of our partners said, you know, we really feel like we were heard and that there was a focus on our population that hadn't been there before. So I think I will stop there and thank you guys for listening and having us present. You can see we have our contact information that you can always let us know if you have questions. Thank you.
Wonderful presentation. Thank you so much. So now we come to the point where we're going to have 15 minutes for open discussion, question and answer. I wanted to just summarize very quickly a couple of things about or across our presentations. One is that there's lots of different terms that our presenters were using for their type of community engaged research, right? We heard a lot of CBPR, or community-based participatory research. We heard about participatory evaluation. We heard about the Freire model, community-based approaches, and then community or critical participatory action research. At the very base of it all, the common denominator is engaging community, right? Making sure that community is involved in research and democratizing the process so that voices are heard and topics that are of a priority are the topic of interest or the topic of research. Another common element across these 4 partnerships was that the funding, that the partnerships were organizations, right? So there's lots of other models. Also, you could have a community advisory board made up of people that are living with or in the situation, organizations, a mixture of the two. And then another really fascinating thing that I heard from two of our presenters was that funders have some control, right? So if you're responding to a funding announcement, or if the money is coming from an organization, they have a certain amount of control over what happens in the time frame. So that's also important as you're trying to develop a partnership and then carry out the research that has been funded. And then the final thing that I'll say is that you can see that this approach is applicable to a variety of health topics, right? So we had healthy weight, we had COVID, we had community assessments on a variety of different things. And then, I'm sure most of our panelists and most of our audience has also other topics that they're doing and using a similar approach. So I'm going to stop there. And Jose, do you want to lead the Q&A?
I can up for a little bit. If we go beyond a little bit beyond 1 o'clock, Dr. Lucero will take over at that time. But yeah, if everybody like to turn on their cameras, and if you have any questions for Dr. Lucero, myself, or Erica and Amanda, who are both on the call, we'd be glad to engage in conversation with anybody. Raise your hands or just speak up and introduce yourself. I see Ron raising your hand. Yes, sir. Go ahead.
First of all, these are great presentations and these are great models, and I think this is very, very important, especially for underserved communities. And so I'm all in favor of this. But as Dr. Lucero pointed out, organizations that fund should have some control. But then how do there's a lot of medical research that is funded where the funder does not control the publication of the research. And that's important because you don't want somebody who has a bias, funding research that then has to come to a predetermined conclusion for it to be published. Think tanks, especially, whether they're right-wing or left-wing think tanks, are famous for that. You fund research, but then, the researcher doesn't get published unless the researcher comes to a conclusion with which the think tank in advance approves. So if you have community-based research here and you have different organizations providing funding, but then the organization puts out a condition that, okay, we control what happens at the end because we provided the money, how do you prevent political opportunists or political extremists from using these organizations to skew where the research goes or to muddy up your results? And instead of having reliable scientifically based research, you end up being the paid political shill of some opportunist. How do you screen that stuff out if you're going to give them control because they have the money?
I can take that. Oh, go ahead, Dr. Lucero.
No, please go ahead.
No, I guess and this is Dr. Marquez, and I think that I think it's making decisions up front about what grant opportunities you're going to go for. And I don't think I would go for anything that would compromise my ability to make an independent decision about the data. So I think that becomes a conversation up front before we even go for certain opportunities. I have personally not have encountered that. But that would be kind of my decision making, I think, at the front end of it.
And that, Ron, that's a great question and a great point, and I can share a real experience of that. Many years ago, when we were looking at doing some community-based work with predominantly Latino communities, at one point when I was just getting started, that issue actually came up because at that point, if you went into the issue was alcohol, right? And where was it being distributed, all that. And so at that point, no disrespect, but Coors was funding a lot of initiatives. And, you could go into any neighborhoods and you'd be hard pressed to find especially some of the low income neighborhoods, you'd be hard pressed to find a Vons or an Albertsons, right? A legitimate grocery store, but you could find all kinds of liquor stores, right? And so Coors was funding these initiatives. And so they actually came to us and said, hey, we have some money to put into community-based work. Would you be able to utilize it? And so our committee at that time went to them and said, we'd be more than welcome to take your money, but you have to know that the work that we're doing is not going to be so put a good spotlight on Coors or alcohol. And so we were very upfront with them. And I think that's the critical part here, communication and being upfront with them. And I know this is hard to say in the nonprofit world, but yeah, sometimes you might have to say, you know what, thank you, but we won't use that money, or we won't be able to use that money because, we're not, part of CBPR is that you have a strong commitment and community has a voice in not only the data processing and collecting the data, but then processing it and interpreting the data, right? They're active partners with us in that. And so I think that's, very honest communication. And sometimes you might need to turn down that money, as hard as that is to say. Dr. Lucero, I know you were going to add something earlier. Or?
No, you guys nailed it.
All right, well, that was a great question, Ron. Thank you. Anybody else? Other questions, comments?
I'll make a comment just really quick, because I think when we think about community-based participatory research or any that spectrum that Dr. Habush went through, I know it can be a little overwhelming to think like, where do I start? How does my work fit into this? And I have to tell you that with some of our partnerships, that when we started some of our COVID work, some of them were newer partnerships. So there was a big trust building phase, right? And some of them were long-term partnerships. And it's okay to be across that spectrum when we're doing our work, because it takes time, not only for us to build trust with some of our community partners, but that trust goes both ways. So I just want to acknowledge that we ideally want to be on that right end of the spectrum where there's this distribution of power and decision making, but I think the reality is that when we're bringing in new partnerships, that we're kind of starting on a trust building phase at the get-go, and so each relationship is kind of on that continuum, if that makes sense.
Are there any other comments or questions? Either about part one or the presentations today?
So just quickly, I want to point out that thank you, Sarah, for putting there is a survey in the chat. If everybody could please log on there and complete it for us, we'd appreciate it. Also, just some quick taking care of some house business here. Any organizations that are on here participating in this institute, if you are not an actual member of the coalition, please make sure and let us know, reach out to us so that we can get you that application. We have a new application that's coming out here real soon. And that way you can, as we get ready to kick off some of the new initiatives that we're going to be doing, if your area of work is in that area and you want to qualify for some of the subaward grants that we'll be putting out for our new work, we ask that you please complete our application for an allied member or an associate member, and make sure that we have you registered with the coalition. So, and that's going to be, I think that work is going to be kicking off somewhere in the next 2 or 3 months as we get rolling with all the new initiatives that are kicking off for the coalition. So critical that we can do that. And again, one more time, 5 more minutes left. Any questions, comments, concerns?
Yeah, this is Vince Collins. I just want to say thank you for the presentations. I'm starting a new organization, and what I'm really excited about in getting this information today is that it really provides an opportunity for like a small organization to kind of focus the framework of their organization in a way that they're able to participate in research projects. Research projects can seem very overwhelming, and as a small organization, trying to figure out how to bridge, your constituents and your population and your scopes of work with really meaningful work within society, right? I mean, and then bridging that in the way that, on the grassroots level, you're doing the work and trying to address, the ills of society, but also lending that sort of effort to the bigger abilities and capabilities of research. And so I just want to thank you for me sort of seeing a way forward in how I focus my organization. And I noticed that some of the participants with Erica and Amanda's projects are relatively new organizations within Nevada. And I've been able to kind of witness how they've been connecting to research projects within this framework. And I can tell you, having been a part of those projects, and it's definitely sort of given it just given those organizations a lot of really good information and been able to allow them to do some pretty good work right off the top. So anyway, I just wanted to mention that.
Thank you, Vince. Right. Anybody else?
I've never been on the nonprofit side of the table, so I'm an academic. But one thing that I've learned over the time that I've been doing this kind of work is that, and academics don't like it when I say this, but the community organizations really have the power in these relationships, because the academic usually needs the community more than the community needs the academic. And so there's so much power in that. And so knowing, like laying out some parameters very early on with your organization on how requests get filtered through and what it is that you want up front, or the organization wants up front from the academic, I think is really good to think about. I once worked with an organization where they would not take less than 30% of the budget because they were being asked to do the recruitment, the research questions. I mean, they wanted to be compensated for their time. So just think about those kinds of things as you're moving forward or being asked about, to partner in a research endeavor as you move forward. Okay, I think we are at time, unless anybody has any other questions.
No, I think that's everything. All right, everybody, thank you so much. Remember, December 3rd is our final session where we're going to be, hopefully, we're still trying to lock them down, but talking about how to fund some of these initiatives and where you can look for funding. So join us again on December 3rd. Everybody should have had that link when you registered, and stay safe and enjoy the holidays, whether you share Thanksgiving or celebrate Harvest Festival, whatever you do, stay safe, and we'll see you all soon. Goodbye.